cover everyone. So we talk, I'll be talking about how first context we are in the one with one outcomes out of the at the end of my talk, we could have answered the following questions. How is a pregnancy dated? How do we assess fetal growth? We're also going to cover which Dopplers are useful in obstetrics and what are some of the clinical applications of Dopplers. So probably just to prove, the workshop right. So one important concept of whatever whatever so what are some of the methods which are used in dating pregnancy? So we've got I think it was mentioned LNMP, but the LNMP dating is different from assumption. This assumption that occurs on number 4. If there is probably a disharmony in terms of those assumptions, dating using LNMP becomes inaccurate. And it has been proven that I think close to 50% of women are uncertain of the date. So to now use the LNMP as a dating method, it becomes unreliable in almost 50% of cases. Then dating these days is now that idea is coming then the ultrasound dating methods would be which is the most accurate with an error margin which is less than a week. Then in the second trimester, just to know, this would after that it comes in accurate. So not average, which will give an average. Let's circumference Similarly, average. In most people, most notebook plans that average becomes inaccurate in a number of things. So, for the trimester, we use the head circumference. Okay. Are we on the same page? Can you tell your neighbor we use head circumference? Important point. I think people from my background, from my common, when I was not born again, someone that was every time they come, they give you every time they come for another friend, they give. So once pregnant, that comes past massive. I also further away. I put further away. What is someone calling that as we? So instead, video scans should help to assess whether the baby is growing well or not. So we mustn't be changing the EDDs. Okay. So what is fetal growth assessment? So the initial, so that becomes working throughout. Okay. So any subsequent scans will now be used for growth assessment. So what are some of the fetal biometry which are used in growth assessment? We've got head circumference and separator diameter. And also remember, these are some of the landmarks. There must be some landmarks. It must be like a rugby ball. It must be every level. The funds whereby you must take one of lateral ventricle. You should be the thalamine and have some box-like structure in the front. Okay. Why is it important to do things consistently so that you can compare? When they come for the subsequent scan, you do at the same level, compare the progression or regression or stagnation. The femur, it's one of the biometric markers we use in growth assessment of the abdominal circumference, which should be football shaped or round. Umbilical vein turning to become the portal vein. You should be able to see your spine at the 3 o'clock or 9 o'clock, not at the 12 o'clock, because usually when it's at the 12 o'clock, the spine casts some shadow, not be able to see the intra-abdominal structures, then the stomach bubble and the adrenal gland. So not everything round is an AC. Okay. We also assess amniotic fluid as part of growth assessment. And in amniotic fluid assessment, we use the Fetal Medicine Foundation. We use protocols which were adopted from Fetal Medicine Foundation UK, which is the global standard. So when you hear about PARI and Salim Gabe fetal medicine units, we are operating at the global standard. I've seen most women, when they are referred, initially they'll be thinking that they'll be having a mentality about PARI and SALI, you know, the general. But when they come, they are surprised. Why? We are operating at the global standard. So they use the single deepest pool because we'll be checking many things rather than the amniotic fluid index. Then there are some graphs which should come out. I will also be talking about them in the next slide. Okay. So, growing well. It's growing according to that. So when a pregnancy has been assigned, and when they come for the subsequent scan, there's two options. One of the options is the machine allows it. Don't just put that scan, the machine not just cannot connect. So once you give input the EEG, most machines will what are called these percentiles will now help you where your fetus is supposed. So there are three main categories. The first category, where the majority of fetuses are, is going appropriate. So when you get the fetus and they are between 10 and 9, very much. Are we following what's happening on? Okay. We were saying next one hour after the as a program. How we are down in grade 6 and no grade 3 goes more. When we move grade 7 and we move grade, so we have to have content. But I was get like a so that's the same thing as it was. So when they are between the 10 and 20, when they are below the 10 percentile, it's more. When they are above the 90s, now they can lie. So as it shows that class is growing appropriate, or it's growing small, or it's growing large, or they are assigned. Are we together? Then in comes the next so what are some of the roles of the Dopplers? It's for antenatal monitoring of pregnancy with the aim of preventing perinatal and so the Dopplers are another direction to say, they're now trying to answer some questions. Why is probably growing some extra in terms of explaining what could be happening, why it is happening, where it is happening. What are some of these? We've got the from the outside one, we've got the umbilical after the Doppler. Then we've got the MC after the Doppler, and we also have the data. So we shall see that these Dopplers are important, especially when we are. I think I will briefly start with my project goals that I mean also going to but these are Dopplers. Where do we do Doppler? We do only if you look just to because it's area proper, which is my course. So when it is normal, the umbilical artery flow resistance. And so, okay. The MCA finding recovery of the split point for second week one high resistance. As you can see on that get away from the so, then the ductus venosus, which is like a smaller that is appearing normal with also a lower resistance. Okay. Then on the extreme right, that's not talking about maternal Dopplers can be I think someone will talk more about it from their talk. So this one normal. So when you come accustomed just do Doppler, before you know that this is normal, just to guess. What is this one? This one is hybrid. Okay. Are we still together? Can I go deeper? All right. So why is surveillance important? Here we are now mainly focusing on the in the next slide on the small fetuses. So research has shown that small for gestational age fetuses who undergo surveillance and timely delivery have a 4 to 5-fold reduction in mortality and or severe morbidity before birth. This is remarkable. So a fetus with small for gestational age and is not being monitored means they have a 4 to 5-fold chance of mortality. Why? Because their delivery will not be optimized. But when they are undergoing surveillance, we can tell that this fetus is now in danger, and we can say, please, can delivery be done in the next 24 to 48 hours so that we avoid having intrauterine fetal demise. All right. So what are some of the key issues? Surveillance of Dopplers usually are done with these goals, which are to once it's also to assess for the risk of stillbirth assess the rate of deterioration, progression, or is worsening of from pushing pregnancy. Then plan the appropriate interval of next visit and time of not early, not but time by the sonographic finding. Okay. So I mentioned about the Dopplers. So we've got the umbilical artery Doppler, the MCA, the Doppler venosus, and these Dopplers, besides high volume, normal or they are normal. Okay. So fetal growth disorders diagnosis. So I will mainly zero in on the SGAs because these ones are quite a huge chunk of what we come across at our fetal medicine units. Why? Because there is a high prevalence of preeclampsia or hypertensive disorders of pregnancy in Zimbabwe. So these ones mainly result in the standard growth of the babies. So of all the SGAs, 20% of them are constitutionally small. They are normal because of one of them or both of them, then the thing also becomes small. That's more growth. Are you getting? They are normal, but they're just small. So that's 50%, about a fifth. Then we've got 15% who are abnormal small, and these abnormal small is a result of abnormality or infection that then the majority are due to almost 2/10 as a result of placenta. Okay. So they are called starving small because the placenta is not feeding them well. So when these small, the FGRs, when the baby is small for gestational age, because at the fetal medicine units, we deal with high-risk pregnancies. Once it's FGA, we already flag them as fetal growth restriction. And fetal growth restriction, we have got two main groups. We've got the one which occurs before 32 weeks, which we call early onset fetal growth restriction. Then if it occurs after 32 weeks, we call it late onset fetal growth restriction. That's the demarcation there on the green, yellow on that graph. So the surveillance tools which we use for monitoring these FGR babies, we use biometry assessment. We now know about LGA, SGA, and under the SGA, there are also various categories because we also be monitoring the baby under the 10, but they are progressing, growing, still under their checking under their 10. So we'll be monitoring that growth assessment. Then we'll be checking the Dopplers, whether the umbilical is remaining normal or whether it is reducing in the end diastolic, because when it deteriorates the umbilical artery, it starts reducing the end diastolic flow. Then in the end, it can actually have absence of end diastolic flow. When it worsens further, it can actually have reversal of the end diastolic flow. So during diastole, instead of blood moving this way, it ends up going the other way around. Then the MCA Doppler, we said it's a high resistance. When it becomes abnormal. There's an increase in that end diastolic portion. So it ends up being a low resistance when it's now abnormal. And we usually refer to that as a trend, which you say it's a trend towards redistribution, or probably one of the common terms which is used is brain sparing. So when there's shortage of supply of nutrients and oxygen, the head prioritizes itself. And how does it do that? It vasodilates and starts shunting blood to the brain while starving probably the abdomen and the femur. Okay. In the ductus venosus, when they are becoming progressively worse, the ductus venosus, it starts with the reduced A wave, then the A wave start to get, which is between the two waves, that trough is the A wave. So if it starts dipping deeper, then it's worsening off, and it's usually an indicator of what's happening with the level of the heart. Because remember, if it comes, okay, so it can end up being absent, or it can end up even being reversed. And when it's reversed, then the baby is in imminent danger of demising. In the amniotic fluid assessment, we know normal range is between 2 centimeters and 8 centimeters. If it's less than 2 centimeters, that's oligohydramnios. If it's more than 8 centimeters, it becomes polyhydramnios. And we also have, it's starting to get popular, the CTG, which is the one which assesses the fetal heart over a 20 to 30 minute period to see if the baby is. So these things all complement each other. So this is so I mentioned about early onset FGR, which we said it occurs below 32 weeks, and it mainly manifests in the umbilical artery Doppler, which I mentioned about the deterioration which occurs. So early onset FGR, it's mainly, we call it, it's a perfusion problem. Why? Because you can pick it by the abnormality in the umbilical artery. Okay. So you can see here what's happening over a sustained period. So babies don't just die. It's something which can be tracked, and you can actually see that they are deteriorating progressively. In late onset, it's usually a diffusion problem whereby the umbilical sometimes can actually be normal. So an umbilical artery, a normal umbilical artery, it's not really a marker to say everything is okay. You have to interrogate the other Dopplers to say if the MCA is also normal. So sometimes the umbilical artery can be normal, but the MCA, once it becomes abnormal, the baby is at risk of fetal hypoxia, which is usually the leading cause of fetal demise. So we've got some algorithms which we use in the surveillance of the small babies. So it's suspected that the FGR, we usually do some 2-weekly umbilical artery Doppler. The Dopplers we do every 2 weeks. We also assess fetal growth. Then if they are abnormal, if it's absent, you can also see what's happening. There is a streamlined care plan which occurs. So what are some of the other, this is my last slide, but the other clinical applications? Both Dopplers are not only used in FGR, are also used in cardiac defects. They are also used in prenatal diagnosis of fetal anemia, fetal growth restriction, ETTS, TEPS. This will be talked about in the multiple pregnancies. And they are also used in fetal surveillance of the FGR. Okay. I think that ends my talk.